Hello everyone, I am Dr. Deeksha Pandey, Additional Professor in the Department of Obstetrics and Gynecology, KMC Manipal, and looking after the subdivision of urogynecology in our department. And as we keep on telling that this month we have dedicated to stress urinary incontinence, and today I have with me Dr. Shreya, a junior resident in our department who will be presenting a little different kind of case in prolapse, and she will be presenting history and examination, and then we'll take it to further discussion.
Good afternoon, everyone. 58-year-old Mrs. X, para to living to, postmenopausal since the past 7 to 8 years, hailing from Davangere, manual laborer by occupation, belonging to low socioeconomic status, came to KH with complaints of mass descending per vaginum since the past 7 to 8 years. Coming to HOPI, patient was in a usual state of health 7 to 8 years ago when she started to develop a mass descending per vaginum, which was insidious in onset and progressive in nature, associated with back pain. The mass would reduce on lying down and increases during her work. Patient also gives history of leakage of urine during coughing or sneezing or lifting heavy weights, which is not associated with any urgency or burning micturition. No manual reduction of mass PV is required for passing the urine. Patient has regular bowel habits, no complaints of defecation. Coming to the medical history.
Just wait here. So patient's chief complaint was mass descending per vaginum.
Yes,
when you asked about stress incontinence, then patient, when you asked about urinary complaints, then she told. But she has not told you in the beginning.
No, ma'am.
So this is one very important thing that all patients, and I think you have not asked, the way we tell how to take prolapse history, first thing is anterior compartment system. First you have to confirm it.
Yes.
Okay. Then anterior compartment, middle compartment or central compartment, or the posterior compartment. So have you asked about central compartment problems?
Yes, ma'am. There's no complaints of white discharge PV,
Okay.
no complaints of any bleeding PV.
And sexual functions.
Yes.
Is she sexually active? That you did not.
Not
That
asked.
we all failed to ask. But I think it is a very important problem and issue which helps in managing also. Because of that, management changes a little bit. So we should not presume things. That's what we have been teaching. We have lived our era, but the patients which you are going to deal, I think that will be, I keep on discussing many those kind of issues which might have gone to even the court of law. People would have taken if you do not ask. We had very embarrassing moments in our practice. So I think it is a lesson for all of you, or it is a message for all of you that please ask. That's why we have divided history into first confirmation of prolapse, then anterior compartment symptoms, central compartment system, very important sexual functions there, and then posterior compartment, and after that we have to assess how much it is bothering the patient and what is the quality of life of the patient. Okay?
Patient is a known case of hypertension on treatment since the past 1 to 2 years. Patient does not give any history of TB, chronic cough or any bronchial asthma. Patient does not give any history of any neurodegenerative disorder or any musculoskeletal disorder. Coming to the obstetric history of the patient, she is para to living to with 2 previous normal vaginal deliveries. Last childbirth was 30 years ago and the patient is sterilized. She's postmenopausal since the past 7 to 8 years with no history of any postmenopausal bleeding.
So again, patient has attained menopause 7 to 8 years ago,
ma'am.
and that is the same duration of
her mass per
vaginum. So usually these prolapse problem occurs at the time of childbirth, but it is concealed till the patient
becomes menopausal.
Yes.
Coming to the personal history of the patient, her appetite is normal, no history of weight loss or weight gain is there. She gives history of strenuous activity on an everyday basis as she is a manual laborer by occupation.
Very important.
And
very good.
No history of weight loss is there. Coming to the salient points, in this case, we know that it is a 58-year-old female who is a manual laborer by occupation belonging to a poor socioeconomic strata, who has history of strenuous activity on an everyday basis with history of 2 previous normal vaginal deliveries, who has come with complaints of mass descending per vaginum and stress urinary incontinence.
Very good. So this you have nicely summarized the history, so we can jump on to examination part.
Coming to examination, the general condition of the patient was fair. She was little bit on the obese side with her BMI being 35 kg per meter square. There's no pallor, no cyanosis, no clubbing or lymphadenopathy. Her CVS and RS examinations were also unremarkable. Coming to per abdomen, she was obese on the obese side. Although her per abdomen was soft, non-tender, there was no mass palpable, no ascitic fluid. All the hernial orifices were normal, and there was no suprapubic tenderness. On local examination, external examination, there was no signs of atrophy or excoriation. Uniform cough stress test, which was done on a full bladder, was positive. On speculum examination, cervix was healthy, although cervical elongation was noted. There was a 4 into 5 centimeter mass coming just at the introitus, which was suggestive of a second degree UV prolapse. There was no cystocele, no rectocele present. There was no decubitus ulcer. The perineal length was 3 centimeter and with a good levator ani tone. On per vaginal examination, all the inspectory findings were confirmed. Getting above the mass was not possible. And on repositing the mask back, the uterus was normal in size, there was no fornicial fullness, and there was no cervical motion tenderness. The sensory and motor integrity of the patient was also maintained.
Lovely. So, tell me one thing now. I don't have to ask anything. I hope you have done properly. Okay, before going there, I'll ask you one thing. You said that this patient has second degree uterovaginal prolapse.
Yes, ma'am.
Now, can you tell me then second degree UV prolapse and stress urinary incontinence? If suppose this patient would have come to you with 4th degree, means procedentia,
Yes, ma'am.
would you have got stress urinary
No, ma'am.
incontinence?
If the patient would have come with procedentia, her major complaints would that be of urinary retention and not that of SUI.
So
she
how
would
is
have-
how is the natural history of SUI in a case of prolapse? So what we are presenting today is not just a simple case of stress urinary incontinence, but what happens when stress urinary incontinence is associated with prolapse. So tell what happens, and so we have 4 stages of
UV
prolapse.
yes,
So
ma'am.
how it progresses.
So what happens in the earlier stages of UV prolapse is due to the laxity of the muscles, the prolapse is happening. Along with that, the neck also, the holding of the bladder neck also gets lax. So the patient will have stress urinary incontinence before. But as the the prolapse comes out and out of the introitus, the complaints of the anterior compartment becomes that of an obstructive
Very good. If
complaints.
I have to give you marks, I'll give you 10 on 10 now. Okay.
So it becomes more of urinary retention than
because
incontinence.
the angle between the urethra and the bladder, because bladder is prolapsing, the urethra is static, it gets kinked.
Yes,
Okay. So there is more of retention problems in 3rd degree and 4th degree uterovaginal prolapse, not of less of incontinence problems. So patient will, that's why it is so important to ask the patient always that, okay, if the patient comes to you when she has procedentia 4th degree UV prolapse, and she says that you ask her, do you have stress urinary incontinence? She will say, no, I do not have.
Yes,
Will you ask her any other question? So what you should ask that earlier.
Yes, yes, ma'am.
When
We should
the,
ask
in the
that.
beginning of prolapse, whether she had it or not.
Yes,
Okay, so what is the significance? Why do we have to dissect her old history and ask whether she had or not?
Ma'am, because from this we'll come to know that previously her prolapse was like maybe 1st degree or 2nd degree and has eventually progressed to this size, and it might be associated with some cystocele also.
This is mostly, cystocele related only. That's why cystocele has come down. That's why kinking is there, and that is not there. But why do we want? We know what is the natural history.
Yes, ma'am.
But is it important for management?
Yes, ma'am, because our line of management will change if there's a cystocele also present along with the vaginal prolapse.
Okay.
If there is no cystocele and there's only a prolapse with stress urinary incontinence, we can think of something like a vaginal hysterectomy along with maybe TVTO. But if the patient also has a cystocele along with the vaginal prolapse, our line of management would be VH plus maybe pelvic floor repair to be done.
Yeah, that is correct. But what I'm asking is little different. Okay, suppose today patient has come with 4th-degree uterovaginal prolapse, and a patient saying that I am not having stress urinary incontinence, but when this problem started 4 to 5 years ago, I used to have stress urinary incontinence, but now patient is not having. So how you said you did vaginal hysterectomy, cystocele repair, rectocele, all repairs you did, and you, because patient is not having SUI, you will not treat SUI. What will happen in post-op period?
Patient might develop SUI post-operatively.
Very good.
This is
Yeah.
called de novo
Very good.
SUI.
So it is called, this is a very important thing. That's why past history of SUI is very important, because if you do not repair it now, if you do not find it out, and patient will again have SUI in post-operative period, and she'll say, what, you have relieved me of one problem, you have given me another problem which I was not having. That should not happen.
Yes, ma'am.
So if a patient, your patient is having just 2nd-degree prolapse, but if a patient comes with 4th-degree UV prolapse, a 3rd-degree UV prolapse, she says 5 years ago or 3 years ago, I used to have SUI, and you are having this fear that patient might go into de novo stress urinary incontinence. How do you examine? Do you do anything in examination? So usually SUI, when you demonstrate, you do it before speculum examination. You tell the patient to cough. So prolapse also comes out and SUI also comes out. But if you have to demonstrate the risk of de novo stress urinary incontinence in a 3rd or 4th-degree prolapse, you reposit the mass back. Okay, because that will be the effect after surgery. So you put the mass inside, keep it inside with the help of your fingers, and then tell patient to cough. Okay, so de novo stress urinary incontinence will be elicited. The risk you will come to know. Okay, so this is very important one. Okay. Then when you said POPQ, you have not done. Okay, something about POPQ. So you also said that patient was not having cystocele, enterocele, rectocele. So if you would have done POPQ in this case specifically, you would have come to know a very important finding. What is that finding?
Of cervical elongation.
Yes. Okay.
Yes,
So
ma'am.
what is the finding of cervical elongation when you do POPQ?
When I do POPQ in cervical elongation, the point C
Very
and
good.
D
They are two
distance.
distance. Usually
Yes.
they are very close to each other in a normal patient also, or in a case of prolapse also. But in a case of cervical elongation, there is a lot of distance, more than 5 to 6 centimeter distance between point C and point D. Okay. And when you palpate, how is cervical elongation felt? Otherwise, entire prolapse, if it comes, it feels like a boggy swelling. Okay. But if you feel only cervical elongation is there, what is the feeling in when you do a PV examination?
Ma'am, a hollow tubular structure.
A tubular,
we can feel.
yes, a
Yes,
tubular
ma'am.
structure, not hollow, a firm tubular structure you can feel. And phonesis, especially the posterior fornix, will be very deep. Okay.
Yes, ma'am.
So these are the findings, so that will change the management a little bit. Okay. So what do you want to do for this patient?
Since ma'am, I know that this patient already has stress urinary incontinence along with vaginal prolapse, we would want to correct her prolapse and relieve her of her
So
incontinence
any investigation,
also.
Shreya, see, you said that actually all the things look here. See, SUI she has,
Yes,
prolapse she has.
Yes, ma'am.
Both are because of laxity of pelvic tissues.
Yes, ma'am.
But why she's not having cystocele? Why this cervical elongation is there? What can be the cause? What are the causes of just cervical elongation? Cervical elongation happens in those cases where something is holding the uterus up most of the times. Actually, till now we do not, there are not many studies finding out the cause of when like supravaginal cervix still we know, but intravaginal cervix when it is elongated, there are not many studies, not much of research work. It is a field of potential research that why it happens. But our understanding over the years, what we have seen that most of the times there is something which is holding the uterus has a tendency to come out, the tissues are lax, but something is holding the uterus up. That's why just the cervix is coming out, getting elongated. Okay. So what is that? What is holding it?
Maybe a fibroid uterus.
Maybe fibroids, yes.
Or maybe mass which is sitting in the on the uterus which is holding
fibroid.
it up.
Okay. On the other thing, you said that this patient has PPS. Sometimes
Yes, ma'am.
earlier surgeries also.
Yes, ma'am.
Sometimes we have discussed this before also that all of us have seen worst kind of adhesions in cases of PPS, because that
yes.
is done by the people who are the junior most and who are learning. That is maybe the first surgery people do.
Yeah.
So though it is a small surgery, but many a times we have seen the worst kind of adhesions with PPS.
Yes.
Okay, so some surgery or some fibroids are holding it, or some PID adhesions or something is holding the uterus up. So only the cervix is getting elongated and holding the other structures intact in their place. So that is also one reason. Adhesions, obviously, you will not know while doing an ultrasound, but at least fibroids or any other pelvic, like stuck ovaries, some idea you will get by doing an ultrasound. So did you do an ultrasound for this patient?
Yes, ma'am. We did an ultrasound for this patient, ma'am. For her uterus was normal in size. Bilateral adnexa was also normal. There was no mass.
No fibroids?
No, ma'am. She had 2 intramural fibroids measuring.
Because I remember surgically when we doing the surgery, we removed some fibroids.
Yes, ma'am. She had 2 intramural fibroids, ma'am. Yes, ma'am.
Okay. So there were some fibroids. That might be a probable reason. We cannot say it with certainty. Okay. So ultrasound was done.
Yes, ma'am. We would also like to do one urine routine, ma'am, to rule out any urinary tract infection. And we would also do CBC to rule out any...
So finding out the fitness of the patient before surgery.
Yes, ma'am.
Good. So how do you do surgery for this patient?
Okay.
Patient is fit. She is not having any other comorbidities.
Yes, ma'am. For her, ma'am, we plan to do VH along with one DVT-O. First, we'll put the patient in dorsal lithotomy position. We'll prepare the patient. Then first we started with vaginal hysterectomy. We'll hold the anterior lip of the cervix.
So is it a simple hysterectomy, vaginal hysterectomy, when there is no cystocele, no rectocele and cervical elongation, or is it a difficult in relation to a normal case of prolapse?
I think it is simpler than...
It is actually a little bit difficult to do, because it becomes like non-descent vaginal hysterectomy. Okay, and non-descent vaginal hysterectomies are always more trickier than a prolapse, because everything is loose there. It is easy to get planes. Here you have to dig inside. The bladder UV fold is very high, so opening folds are difficult. So these are the surgeries which are little more, I cannot say that very tough, but yes, if you compare it with a normal case of prolapse, where the tissues are much lax and introitus is big, these are little difficult surgeries. Okay.
Then, ma'am, we open then we cut through the cervicovaginal junction, and then we'll clamp the Mackenrod's ligament, and we'll go higher up. Then we'll cut and
before that, always before Mackenrod's and uterosacral you can still do, but before you do uterines, always you have to open the
pouch of Douglas.
Anterior pouch, UV fold. Okay, so anterior pouch, one pouch at least. What I feel is one pouch has to be opened before you start your hysterectomy. Okay, so at least posterior or anterior. Posterior, most of the times it is easier to open, so we usually open posterior. And even if, like in this case, I said that the UV fold will be very high, so it might not be feasible to open both the pouches, but at least one pouch you should, because you might be accidentally like getting some loop of bubble or some injury might happen. Okay, so at least one access should be there. Anteriorly you put the retractor and start clamping the Mackenrod's and uterosacrals. But before doing uterine, see, always, even if you are doing an abdominal hysterectomy, laparoscopic hysterectomy, any kind of hysterectomy, before you go to uterines, you have to cut the UV fold and push the bladder away. Okay, that's not only important for just for the bladder, that you can say that I am seeing bladder, I can prevent that. But when you push the bladder down, it takes away the ureters also. So ureteric injuries also.
Then we go higher up. After our uterines, we'll cut and ligate the corneal structures.
Before, if that there is no place in this patient, what we did, you remember? They removed the fibroid uterus. So debulking, if you cannot go, because sometimes similar to NDVH, we are not able to go to the fundus in these cases. So you can either hemisect the uterus or you can debulk by removing the fibroids individually.
Yes, ma'am. In this patient, since we preserved the ovary, after the uterus was taken out, then we did the vault closure was done for this patient. And then we'll preserve one important thing that we did in this patient and that we should remember is that the surgery was done under spinal anesthesia so that we could elicit stress urinary incontinence. while doing the surgery also. Then after vault closure was done, we proceeded towards TVTO. What we do is that in the mid urethra at the anterior vaginal wall, at 1 centimeter away from the urethra, we'll make an incision, and using our scissors, we'll open the pubocervical fascia and we'll go towards the ischial ramus on the either side, and using the winged uh,
You saw the surgery.
surgery.
You
Yes,
saw
ma'am.
the surgery.
Yes,
Did
ma'am.
we use winged one?
Yes, ma'am. We use the winged
No.
one.
There is difference. Have you seen this? I think you have read it somewhere. There are two approaches to do obturator.
Yes,
One
ma'am.
is from inside out.
Yes,
The
ma'am.
other is from outside
Outside
in.
in.
How did we do?
From outside
We did
in
from
went.
outside
Right.
in. Okay.
Yes, ma'am.
So for inside out approach, you have to have a winged guide.
Yes, ma'am.
Okay, so we did not use that
Oh,
wing
yes, ma'am.
guide.
Yes,
Okay,
ma'am.
so wing guide is to protect the bladder and the urethra when you are going from inside to out. But here, what we are using in our hospital is outside in approach. There, you don't need wing. There, we
Okay.
put our finger on one side
Yes, ma'am.
and put one helix. That is called
Oh,
helix.
helix. Yes, ma'am. We use the helix
Mm.
to put up a mesh.
And where do we give this incision? Outside. One, you said one
One.
incision in the vagina,
Vaginal.
anterior vaginal wall, and the other incisions
Just above the obturator internus muscle on the
on where
either
patient's
side of the
body.
labia.
So just below the insertion of adductor longus tendon, just below on the groin,
Okay.
just lateral to the groin, and the insertion of adductor longus tendon.
Okay. And then we adjusted the tape. We should not adjust the tape too tightly also, because when the patient comes out of spinal and the tone of the muscle will increase, patient will develop unnecessary retention of the urine. So we keep it a little bit loose. And here in our hospital, we do not cut the ends of the tape, because later we want to see whether if the complaints of stress urinary incontinence are relieved or not, so that later if the symptoms still persist, we can adjust and tighten the tape for the patient.
Okay. So last question I'll ask you. How do you adjust the tape?
Okay, ma'am.
So now this we have discussed many times. Procedure we are showing surgeries also. So suppose surgery is done. Important thing you said that the ends which are coming out of the groin we have not cut. We have rolled them and put it inside a bandage.
Yes.
Okay, patient was sent to ward. Then
Yes.
what happens?
So if we want to adjust the tape, 48 hours to 72 hours of the surgery, we can do it. We should do it on a full bladder.
When do you remove the catheter?
Ma'am, for this patient, we remove the catheter the next day itself. Yes, ma'am. So we make the patient full bladder. Again, we make the patient lie down in dorsal lithotomy position itself, and we will elicit, we'll do the uniform cough stress test to see how much urine, if it is coming out at all or not.
Whether her symptoms are
And
relieved
still,
or not.
yeah, but if the symptoms are still persisting, then we will tighten the tape from the either ends. We'll try to tighten it from both the ends, and we'll ask her to cough again and again until she's just passing maybe a few, like
No.
1 or 2
Now,
drops of
now
urine.
she's not under spinal anesthesia. Now it should be good.
Okay.
Now she should be dry.
Okay, ma'am. Until she becomes completely dry, we keep on tightening the tape. And when she says, when we see that there's no further urine dribbling, then we cut the ends of the tape there only.
No, then maybe it has become too tight. How do you check?
Uh,
One thing we have to check that it is not loose.
Yes,
Maybe
ma'am.
when you are tightening, it has
Yes, ma'am.
become too tight.
Yes, ma'am.
And patient is not when she's coughing,
ma'am.
she's not leaking. So how do you check? That also should be.
Yes, ma'am. We have to see that patient is passing urine and there's no retention of the urine
So how
happening
do
later.
you check that?
Then
that moment only, when you have tightened enough before cutting the tape, you tell the patient to go and pass urine.
Yes,
And ask whether she was able to empty her bladder completely and whether the stream was clean or not, or she was having it obstructed stream if she was having. Once even she says, then again you have to do her ultrasound.
To
An
look
ultrasound to
for
look for post-voidal residual urine. Because maybe patient feels that she has emptied, but if certain amount of urine remains in her bladder, what can be the complication later? Residual urine, if it remains, she will keep on having episodes of infection, cystitis again and again. We don't want that, okay? So it should be a certain amount of very less residual urine in the bladder on ultrasound. So how much is a normal ultrasound measured?
I think around 60 to 90
Oh my
ml.
God. Make it 50 to 100.
Okay.
Okay. So best is 50. If it is less than 50, it is very good. If it is up to 100, that is acceptable because we consider that maybe in post-op period patient is having pain, some edema is there that gets over perfectly. But it should not be ideally more than 100, except in some situations, okay, that we are not going to discuss. So how was this patient?
Ma'am, for her post-viral urine on ultrasound was almost around 50 to 60 ml only.
Okay.
So we knew that we have not tightened it too tightly.
And did she require tightening of tape post-operatively?
She did require tightening of tape,
Yes.
ma'am, post-operatively.
We had to tighten it a little
Yes,
bit.
ma'am. Yes, ma'am.
Okay.
Yes, ma'am.
So after that, have you discharged her?
Yes, ma'am. We have discharged her. Her complaints of UV prolapse and of SUI have gotten completely relieved now.
So when do you want to follow up? Also you can say that now your complaints are over, go home and no need to come
No,
back
no,
to
ma'am. We
hospital.
definitely want to follow her up. We've asked her to come to us after 6 weeks to
Okay.
look for again if there any complaints of SUI is there
No,
or
I
any
hope
retention
no.
is there.
It should not happen.
Yes,
Okay.
ma'am.
But we have called her for a different purpose. Why we have called her? Complaints, obviously you will talk to her, you will find, you will examine, everything is fine. But that is not the sole purpose of calling her. What do we want? We want to give her pelvic floor muscle training.
Yes, ma'am.
Because she has a tendency of lax muscles, and now as she is aging, this time you have done surgical repair, but muscles should gain strength, and muscles will gain strength when they are tuned to exercise. Okay, so we always tell that your job is not done just by taping and relieving her symptoms once, because it is natural degenerations of tissue will happen with age, and if she does not look after her pelvic floor muscles now, she might come with recurrence of the symptoms. Not just this, she might come with now uterus which was holding the cystocele and like the support is gone, now ligaments are gone. Patient might come with wall prolapse, patient might come with cystocele. So you do not want to take care of one thing and start a new thing for the patient. So always explain to her the importance of pelvic floor muscle training. It is not the primary therapy but adjunct to the surgical treatment. Is it okay?
Yes, ma'am.
Should we stop here?
Yes, ma'am.
Next time when you present, you will do POPQ.
Yes, ma'am.